So, welcome everybody. This is episode 5 of podcast of prostate cancer, prostate disease. I have the pleasure to have with me today Stacy Loeb from New York. She will be speaking to us about addressing the gaps in healthcare provider knowledge regarding germline testing for prostate cancer through development and testing of a virtual genetics board. So it's a very new topic. So I'm very happy to know what she has to say to us because it's something that probably most of us don't know about it. And going through the manuscript, it seems very important for everyone to have a germline testing board in their own hospital. So I will ask you to introduce yourself, where you work, and what are your main duties in the hospital, please.
Amazing. Well, thank you so much for having me. I'm Stacy Loeb. I'm a urologist at New York University and the Manhattan Veterans Affairs Hospital, primarily focusing on prostate cancer and men's health.
Okay, very good. And tell us something more about your research. What was the input actually to develop such an innovative, actually, type of research? But even if it's a brief communication, I think it's groundbreaking.
Well, thank you. That's a great question. The real impetus for this is the fact that germline testing has really taken a much more prominent role in prostate cancer care recently. In fact, it can affect screening guidelines, the treatment of prostate cancer, but also has implications for hereditary cancer risk for both the patient as well as their family members. But despite the importance of genetic testing in prostate cancer, it's really underutilized. And there's a whole host of reasons for this. Some of them are related to the patient, but others are related to healthcare providers. This is a very new area, and we did a survey that showed significant gaps in the knowledge and training of urologists, in particular related to genetic testing. So the real impetus behind creating this virtual genetics board was to provide a multidisciplinary discussion and a way for different kinds of healthcare providers to really learn more about genetic testing and see the ins and outs in a case-based fashion.
And tell us, because a lot of residents actually hear our podcast. So, can you tell us a little bit what is the actual role of genetics in prostate cancer overall, briefly, as a summary? Because probably most of the residents, especially in the low income part of the world, probably don't even really know what it's the exact evidence that it's available right now and what are the indications.
Good question. So it's really become increasingly clear that a subset of prostate cancer is caused by hereditary genetic factors. There are genes such as the BRCA genes, which many people have heard of. This is what Angelina Jolie, the actress, had a prophylactic mastectomy. So a lot of people have heard of the BRCA genes related to breast and ovarian cancer, but not so much related to prostate cancer, even though they are associated with prostate cancer risk, for example. So that's just one example of the genes that has been found to be associated with prostate cancer. And patients who are carriers of pathogenic variants in BRCA2, for example, they should have earlier prostate cancer screening than the general population. And also, they may be eligible for different types of treatment for metastatic prostate cancer. So, actually, now we've come to an amazing time in medical history where targeted therapies are actually getting approved for the treatment of cancer, where if you have a specific genetic pathway that is found to be involved in your cancer, that you may be eligible for a drug that is not otherwise used in prostate cancer. And so by doing things like germline genetic testing and also somatic testing or testing of the tumor, sometimes we can unearth a specific pathway that is active in an individual patient, and they become eligible for different forms of therapy to treat advanced prostate cancer. But knowing about these genes is very important because even if we're treating the patient with prostate cancer, he may have brothers, sons, daughters. Also, the female relatives, may be affected if there is a hereditary variant in the family. And so it's really not only relevant to the patient himself, but also to his family members.
And tell us what was the main focus of your research actually? What did you analyze in your paper?
This paper was specifically about a virtual genetics board. So it's basically like a tumor board, but instead of hosting it in one hospital where it's really restricted to just that group of people who are involved, this was held virtually with people from all different institutions and was open to participants joining virtually to watch. So I think it was really a great way to get multidisciplinary experts from medical oncology, urology, clinical genetics, all together discussing different cases and some of the complexities in the management of the genetic results. So this paper was really an evaluation of how we did with this virtual genetics board. We did surveys both of the people who watched the genetics board as well as the people who were in the genetics board to see how useful it was and whether the information provided was the kind of thing that would be helpful for their clinical practice. And the results really were overwhelmingly positive, that both participants as well as the people on the panel felt like they learned a lot and that the sessions were really useful for education. So I think this was very exciting. It's not the first study to look at a virtual tumor board, but to our knowledge, it's the first study to look at a virtual tumor board specifically to discuss prostate cancer genetics.
And why do you believe it? Because I mean, probably the number of cases that you can bring to a genetic board are not that many as one of the tumor board, right? So, in your opinion, what is really different from a tumor board? Meaning, are there different specialists that we won't find in a tumor board, and how it was more personally enriching for you?
Definitely, there are different specialties. I can say, at least at our hospital, clinical genetics professionals are not typically involved in the tumor board discussion. So that would definitely be a unique expertise to bring in, which really is relevant in this era of precision medicine. So that's definitely a great feature. And really just the fact that it's open to anyone without any kind of geographic restriction. And you're right, you can't discuss a million cases. There is only so much time in each session. However, we made an effort to choose cases that really represent some of the most common scenarios and issues that are faced when you do genetic testing in clinical practice. And then sometimes we would discuss a little bit of a variation on the case at some point along the way, just to capture the other kinds of cases that might be submitted.
Okay, and tell me something. But what a urologist, a mean urologist, even not specifically trained for this, should know about genetics? Because I think that the median knowledge is pretty low because normally, because there are strange cases, normally you just, well, probably a lot of urologists treat them wrong because they don't even look at germline mutations. So, what's your opinion on this, to have a little more idea? As I said before, especially for residents, which probably will be very interested on the subject, because I mean, it's, as I said before, it's groundbreaking. It's a different way of thinking oncology. It's a different way of approaching an oncology patient.
Great question. So I think some key takeaways in terms of what to know about genetics are, first of all, that the family history is very important. And, when I trained, a lot of people were just asking the patient if they had a family history of prostate cancer. And that is important, but really we need to do much more than that because, like I mentioned, some of these genes are also related to other types of cancers in both females and males in the family. So it's actually really important that we ask our patients more of a complete family cancer history, including things like relatives that have breast, ovarian, pancreatic cancer, gastrointestinal cancers also. We do learn about Lynch syndrome in urology, but typically more so with respect to things like upper tract TCC. It isn't thought of as much with respect to prostate cancer, but actually, many of the Lynch genes are associated with an increased risk of prostate cancer and diagnosis at an earlier age. So, those are some relevant genes to be aware of too. So, I'd say number one take home message is asking a complete family cancer history. Number two is all patients with metastatic prostate cancer should be getting genetic testing, full stop. So they don't have to have a family history of anything because it is so important for the management of metastatic prostate cancer, irrespective, even if you have absolutely no family history, doesn't matter. All of those patients should be offered genetic testing. And really also for high risk localized disease where they have a high risk of progression. And because of their higher risk disease, they're more likely to actually have one of these genetic factors. So I would say those are two of my immediate take home messages. And, genetic testing is very complicated. So I guess a third take home message is to, get to know the genetic counselors, in your area. At least here in the United States, there is a national organization of genetic counselors, and their website has a tool to help you find a genetic counselor in your area. So if it isn't available in your clinic or hospital, and there may be similar organizations in other parts of the world as well. But I definitely think that referring for genetic counseling and testing is an excellent idea, especially for urologists who, don't specialize full time in this area since it is complex. But definitely our Tumour board sessions are actually still available online. And so it is possible to watch them for anyone who is interested in learning a bit more about, how it's done and what kind of impact it has for prostate cancer care.
Well, I think that is so. The take home message, if I get it, it's actually that it's not that you will ask for some genes. I mean, you need a specialized medical doctor to give you a complete, a specialized, personalized, let's say, analysis of the genes that probably may be or may have some mutations. So I think that's an important message because that's not that difficult to do. Probably it's more difficult to understand which genes to ask for. But I think that's a very important take-home message for everyone. And another important question for you is what are the gaps in the literature right now for germline testing? Meaning that for most of the people who will hear this podcast is that probably sometimes you don't have the answer or you have always an answer. What is the actual literature that helps? And is there sometimes that you find some mutations and you're not able to give any particular solutions and it gets just like informative? Can you tell us something more about that?
For sure. So that's definitely an issue. So there's really kind of three results that you can get if you do genetic testing. One of them is that it's negative, everything is fine, nothing was found. The other one is that it's positive or a pathogenic variant. There is a heritable mutation that is present that is associated with risk. And then there's this middle category that's indeterminate, we don't know. This is called variants of uncertain significance, or VUS, where at this point it's unknown whether they do have a relationship with an increased risk of cancer, and so it's still being studied. And so it is possible for patients to get those indeterminate results where we don't really know what to do with it. Now, I will say, even if patients get a result that's positive, where there is a pathogenic variant that is associated with increased risk, some of these have precision medicine targeted therapies available. For example, BRCA2. For that particular one, there are actually FDA approved drugs that could be used, such as olaparib. However, there are others where there isn't yet a specific targeted therapy available. But that is a very rapidly evolving space, and new approvals do keep happening. And so I definitely think that over the next 5 to 10 years, we will see many more situations where there is, an actual targeted therapy available for more genes than we currently have now.
So, and why? And you do it virtually because it's difficult to do it locally, or what is the main reason for going virtual for these meetings? Was
The reason for going virtual for these meetings was to be able to expand participation. We had both panelists and participants from all across the US. So if I just held this in a conference room at NYU, for example, then somebody from California or Maine wouldn't be able to participate in that session, and also we would be limited to our local faculty at our institution. By conducting it virtually, we were able to get expert panelists who are really at the top of the field from all across the country, and anyone who was interested from across the US was able to tune in. So I think it really did add an advantage there of expanding the geographic reach as well as the multidisciplinary expertise that was possible in terms of weighing in on these complicated cases.
Well, I believe it's all of the people that will hear our podcast will probably try to connect to the next one because it's probably something to see. I believe because I mean it should be completely different from a regular tumor board. So I suppose it is very. What's the platform where you run these meetings? Is it a Zoom normal platform?
Yes.
So and you find it on the NYU site, or is it, or you just post it on your social media?
So
Uh,
we actually have a whole separate website where all the virtual genetics boards are stored. So we could definitely share the link with the podcast notes as well.
Good. That's good because I think that it's something that everybody should actually see at least once, probably because it can be exported or to other countries. Because I think it's not something that we've heard a lot about it, but I think as you said, we're moving towards a precision medicine. So I think that we should get used to study patients a little more and not to treat all the patients the same way, because probably all the patients that don't actually do good on certain therapies it's probably because of that, because they have certain mutations or a different genetic background. So probably I believe this is a good thing. I really believe that something that will improve all these sorts of meetings for me in the next future will be the fact that we will be able to be almost in person in the metaverse, as they say. So we will be able to talk to each other in a different way, and this will improve in the future the virtual meetings, because I really believe with all the frenetic lives we have, we really need different ways of communicating, and research is just speeding up because of that. So my last question is: what are the next steps for this research? What do you think that it's next after these interesting findings?
Thank you. That's a great question. Really, we're just interested in coming up with different tools and pathways to help make it easier for urologists and other doctors to do genetic testing. So, in one of our other studies, we created a tool. It's called the Helix app. You can actually find it online. It's at helix, HELIX.guide. And this is to help determine which patients should be referred for genetic counseling or genetic testing. So you can answer some questions about your patient and find out if they meet criteria for testing. So I think our goal is really to see what other kinds of technology solutions we can find to address this problem of the underutilization of genetic testing.
Yes, because I believe that one of the main areas where genetic testing is used is probably in mutations in childhood, especially. So I really believe that this is something that every country has, because normally, especially for hereditary diseases, normally you go to a genetician. So I think that we all have a genetician in our hospital or at least in our city. So I really believe that people who is hearing us should just take example from this experience and try to see if it's something that it's actually doable internationally. Probably doing it all together is difficult because all different countries have different laws and different therapeutic solutions. So maybe it's not doable internationally. But I really believe that this is an interesting and it's a novel research. It's not something that we are used to see in the everyday PubMed research. So I really thank you for considering prostate cancer, prostate disease for this important research. We really look forward to having more initiatives like that. And I really believe that we will attend your genetic tumor board to see something more about it. So I'll give you the word to conclude so that you can tell us something more of the next steps that will take you to your next publication on our journal. So
Well, I just want to thank you so much for featuring the study, and hopefully the listeners will find the discussion useful. And if anybody wants to see really how genetic testing plays out in practice, you're absolutely welcome to, watch any of the recordings. And I think it would be great if other people in different countries want to adopt something like this to help get genetic testing off the ground in their countries.
well, the channel is going pretty well as a number of viewings. So I think we will try to make the links directly from the pecan tweet that we will make. So if you just put your site on, so we can actually all go and take a look at this interesting genetic tumor board. So I will finish this thanking everyone and thanking everyone that will listen to this interesting podcast. And so stay tuned for the next episode. And I really thank everybody for listening to this interesting discussion with Stacy Loeb. Thank you.